Hey guys, welcome back to the FOAMfrat Podcast. It's been a little bit since we've put out a podcast. We've been heads down working on a trauma course. You've probably seen a ton of new trauma classes going into studio, but we wanted to get out one before the end of the year. Sam met a young man named Dr. Harrison Brookeman, right? Is it Harris Brookeman or Harrison?
Harrison. You're the one who interviewed him.
I know. I called him Harry for the whole thing, so I don't know. No, you guys met. Where is it? Echo, I think.
Echo or AMTC. Yeah, Nikhil Williams introduced us.
Yeah, and he's been going back and forth. We're like, what do you want to do a podcast on? He mentioned sodium nitrite ingestion, and we were like, oh, that's very unique. That's interesting. And as I started interviewing him and talking to him and asking him where this came from, I was, I don't know, I was blown away. It was really interesting, and he's very well versed on it. But it was interesting to see why this is something that you may run into, and some of the antidotes and the treatments and transport considerations, where you're going, destination. I definitely thought was thought provoking. So I think you guys would enjoy it. Sam, you listened to it this morning during your workout. What were your thoughts?
Yeah, the whole methemoglobin pathway for different things. This wasn't, just as a poisoning in general, this wasn't on my radar. Even when I redid the tox class for us, that Hunt for Poisonous Things lecture, this didn't even come up on my radar. And I went through a lot of different tox stuff. And I was searching through my presentations to see if sodium nitrite or Na nitrite even came up with any results in my many presentations. And the only time it came up was in my toxic inhalation class, where it talks about Fe3 plus and 2 plus, and kind of like methylene blue takes it this way and sodium nitrite takes it that way, but never as an actual overdose where that was the agent. So this was really interesting to listen to. Reminded me a lot of those case reviews that we used to do, and you mentioned one of them in the podcast, where it was a Oragel overdose for a kid, and we used to do a case review on that, where they'd take everybody through the house and show them all these different pictures, and inside of the medicine cabinet there was all pediatric medications, but there was one max strength Oragel in there, and the kid had the like methemoglobinemia issues, and those are super interesting cases. Anytime you get into anything that involves like cyanide, hydroxycobalamin, sodium nitrite, sodium thiosulfate, like all that kind of stuff is really hard to remember. Like as I was going through some of these old classes, I'm like, man, I really had to study up to present that stuff. And as I'm going through, I'm like, man, if I had to give this lecture with no notice, I would be like kind of hard up to present that with no notice. And so I think anytime you encounter a substance that's similar to these, it's really worth getting poison control on the phone as soon as possible, because your transport considerations, some of the complications of them are just in general really hard to remember unless you have like repeated exposure to that or see it on a regular basis. The pathways are, unless you're a toxicologist, like you're just going to forget those things over time unless you have regular exposure to them, even if you've studied up and given a class on it. So one thing that I did pull out from those lectures that I think is worth like noting as you go in, is you were talking about some of like the signs and symptoms. I pulled up this graph from, where is this from? Core EM. And the percent of the methemoglobin in the blood is like, if it's, 0 or 3, it's really nothing. 10 to 20 is when you can get that like chocolate brown blood, cyanosis and stuff. And then it really gets serious after 50%. That's when you can get like seizures, coma, ischemia, metabolic acidosis and stuff. And once you get up to that like 70%, it's like most of the charts that you look up will just say severe hypoxia, death, and things like that. So if it seems really serious, the patient is probably over 50%. And like how long are they going to take until they get to that 70%? So really time sensitive.
Yeah, I remember hearing a physician one time at a conference, I think it was a toxicologist, but he was talking about how sometimes these babies come in and they're just fussy, they're colicky, they're crying, they're showing some cyanosis. And that's one of the questions that they do in the interview with the parent, is ask about it. Because, teething I went through it 3 times with my kids, and it is terrible. They're crying, you're doing anything to try to relax them. And then Obviously not the benzocaine, but you could see if you didn't know about that. I don't think I really knew much about that before becoming a parent and having the pediatrician tell us, yeah, avoid any of the canes on these. But even when I go to I remember I had some dental procedures a while back, and they did a benzocaine, and just sitting there thinking about it, I'm like, oh man, I'm gonna go into methemoglobinemia.
You're like doing a little lancet stick on your finger to see if it's dark or not yet.
Yeah, well, and so those things have a little bit of epi in them too, and so it gave me this anxiety because I was like, oh my god, I'm feeling it right now. I'm feeling it. This is what it feels like right now. I wonder what my blood color is. And it was I was like, man, I feel weird. And they're like, oh, it's got some epi in it. And I'm like this guy's a paramedic. And he's thinking you feel yourself going into it. But I just remember thinking like babies get fussy, so I'm going to get fussy. And it was like I don't know, it was like a concern. And so when Jared Millard went on that call and then he came back and he was like, dude, we started the IV on this kid. I was all happy we got the IV, and then the blood comes out and it looks chocolatey, and I think it was an alien or something, dude. Like, I don't know what was going on. That's something that EMS could pick up on, and like he mentions in the podcast, finding a place that has methylene blue, and I don't want to spoil the whole thing, but that's really important. I think it's most places, but that would suck if you get there and they're like, we're fresh out. All right. Well, let's roll the episode. He was a wealth of knowledge, and we appreciate him coming on. Yeah, dude. So tell us just a little bit about you. This is your first time on the podcast, but you and Sam and I and Brian have been texting back and forth. Yeah. Was it Nikhil that introduced us, I think?
It was, yeah. He and I run the same volunteer rescue squad back in Virginia, so he and I are buddies.
Dude, so I love talking to EMS people that then went on to become physicians, and just picking your brain on what that process was like. Like, how are you functioning right now? Are you doing all right?
Yeah, it's it's been a long journey. I started in EMS back in 2011, so we're in year 14 of this, and that was just as a volunteer in college. And had no intention of going into medicine. I just wanted to drive the truck with lights and sirens and do something fun for my community. And here we are. I kind of denied my path into medicine for a little bit. I studied electrical engineering and I worked as an engineer, but I spent more time in my volunteer firehouse and rescue squad than I did my engineering job. So I pivoted and got a job as a firefighter and a medic in Northern Virginia. And then, I really liked the medicine and kind of pivoted and did a little career changer program where I took all the biochem and biology and stuff.
It looks like you kept the firefighter mustache, though.
Yeah, I got to be able to interface with the fire department.
Mingle with the common folk. Yeah.
Yeah. But here we are, I'm kind of back full circle riding around in a car with lights and sirens again as an EMS fellow, which is pretty awesome.
Dude, that's super cool. And so you are now in a residency a fellowship, EMS fellowship?
Yeah. So I'm at the University of Texas at Austin, and so most of my work is with Austin Travis County EMS, but we oversee Austin Fire Department and then also Texas DPS as well, which is pretty sweet.
Awesome, man. Well, we're happy to have you kind of helping out with some of the stuff on FOAMfrat. I know we asked one of the topics that you're passionate about and trying to dive into different case studies and areas that we could have a good discussion on. And you mentioned a topic that we've covered in blogs and stuff, but we've never really done any podcasting on it, or at least a case study. So I know before we get into it, you wanted to put out just a little bit of a disclaimer, and just listening to it, I think that's actually super beneficial. So the stuff we're going to talk about can be a little sensitive, right?
Yeah, I think that we all have a really difficult job, and the mental health aspect of our job is, although more forefront of the conversations that we're having, it's still something that folks struggle with. And so, I want to preface this that we're going to talk about some hard topics. We're going to talk about intentional overdoses and suicide attempts and things like that. And so anytime I talk about this, I want to throw out there that, there are resources specifically to first responders, specifically to healthcare workers, whether it's the IAFF Center of Excellence, National Volunteer Firefighters Council, or NAEMT. They all have some mental health resources. And then also, I'm out there on social media, LinkedIn, whatever, however you want to get in contact with me. If you're struggling with a call and you hear about this podcast and you want to talk more about kind of first responder mental health, I'm always out there willing to help folks out. So, this is going to be a heavy podcast because it's going to talk about intentional harm, but it's going to be hopefully preparing you to be able to respond to these and help these folks out. So.
Yeah, dude. So when we were like, "Hey, what's a topic you're passionate about?" and you're like, "Oh, we could talk about sodium nitrite ingestion." I
Yeah.
was like, "Wow, that's very specific." And so I was talking to Sam and Brian today, and I was like, "Yeah, I'm doing a podcast with Harrison tonight," and he's like, "Oh, what's the topic?" And I'm like, "Sodium nitrite ingestion," and he's like, "Oh, that's very specific."
Yeah.
And he's like, "What is that?" And I'm like, "I think it's like a food preservative, like meat curing type thing, but
Yeah.
it was not on my radar." So I wanted to know, where did this topic even come up with when it
Yeah.
comes to Harrison's brain? Like, what did you have a call, or was this something you studied, or
Yeah. So
how did this come to fruition?
when I was in residency, we covered the Central Virginia Poison Center. And so we would do a specific toxicology rotation where we would spend time in the poison center. And we'd work with our toxicologists and review all the cases that had been called in over this large geographic area every morning. And then we would sometimes round on the hospital on folks that had a toxicology consult. Most of those were like snake bites. But I actually experienced a couple calls into the poison center for these like chemical suicides where folks had ingested some type of chemical in like things that were posted in online forums and wanted to learn more and kind of dove headfirst into a couple of different cases that had happened. And this is one that, if you look at the published case literature, has become more prevalent since like 2018, 2019. So it's something that I want folks to be aware of. But also these effects can come from, other medications. They can be iatrogenic. Things like benzocaine can cause some of the same effects. Other medications like Dapsone, things we don't use as much in the United States anymore, can cause a lot of this. So that's kind of where it stemmed. Then actually, as part of my EMS rotation in residency, I went down to Anniston, Alabama, and got my hazmat technician.
Oh,
Most
awesome.
people probably wouldn't do that with their elective time. They'd probably choose to, put their feet up and maybe do some virtual work. But it was a good time, so I highly recommend folks try and take a class down at CDP. It was pretty awesome, and that kind of got me more into the hazmat sphere as well.
Dude, talking to toxicologists, there is a podcast. Have you ever listened to the Dantastic Mr. Toxin Howard? Do you
No,
know?
I haven't.
Oh my God. It's Dan Rao, or not Dan Rao, Howard Greller
Mhm.
and Dan, I can't remember his last name. But they do a podcast and they break down tox topics.
Mhm.
And they're really funny. And so I remember when I was the speaker manager for WEMSA, the Wisconsin EMS Association,
Mhm.
I reached out to both of them and I was
Yeah.
like, oh, Dan Raciniak, that's his name, Dan Raciniak and Howard Greller. They're both toxicologists. And I reached out to them online. I'm like, I love your podcast. I'd love to have you come to Wisconsin and do like a little, talk or whatever, but I can only pay you guys $500 a piece.
Yeah.
And they were like, we'll do it.
That's
And I'm
awesome.
like, no way. So they came, and then I got to go have dinner with these. And I mean, they were older guys. They're like in their 50s maybe.
Right.
And just the conversation, like how they just passively talk about the oxyhemoglobin dissociation curve and the Krebs cycle, and it's just normal talk for them, and they're explaining things that I'm like, man, if I were to go into any specialty, and I know it's a lot of schooling, but toxicology is so cool because it takes the things that we all learn that we're like, okay, we'll learn through this, and then we understand at the end you just
Mhm.
put a tourniquet on. It takes those cycles and it makes them now where they're like realistic to you, and the electron transport chain and
Yeah.
some of the stuff that we're going to discuss this evening. So
Yeah.
super cool. That's awesome that you got to do a little tox. I don't know, what do you call that, rotation then?
Yeah, it was like a 2 week rotation or 3 week rotation. And where that I felt like that kind of came into EMS is one of the things I've always thought about is, as a medical director, I don't want to send any of my folks downrange without having also experienced some of this stuff as
Oh
well.
yeah.
So I don't envision myself ever being the one to go plug the chlorine leak or whatever in a level A suit. But, I want to know what it's like inside that suit. So when I ask them to do certain medical things, I've been there and kind of know what it's like to work inside of that. So that was really a lot of my motivation for doing that.
So walk me through what one of these calls may look like. Like, let's say you and I are partners. You're back to your paramedic days,
Yeah.
and we get called out for. I'm guessing if somebody wanted to, self-harm, somebody finds them at this point,
Yeah.
and they're calling us because they're unresponsive or they're
Yeah.
altered. What does that look like?
Yeah, so let's run through a case, and this is kind of similar to the case that I had back when I was in residency. So more often than not, in this specific case, it's 20s to 30s-year-old male. It's male predominant versus females, and they're found unresponsive or they're found having difficulty breathing, something like that. So you get called out for a respiratory call. Let's say a roommate came home and found their roommate on the couch, difficulty breathing, just kind of looking bad. So you walk in the room, and it's really a lot of that kind of nonverbal stuff that you pick up that might start making the antenna stick up on the top of your head. It's things like you might see a glass with like a cloudy fluid in it. A lot of these like pink curing salts are that's kind of that sodium nitrite content that folks can get over the counter. They can get at the grocery store. They can get off Amazon. You can also get it as like an industrial chemical. It's like a yellowish fluid. And then these folks, they on the looks like crap scale, like you walk in, that person's just going to look like
up here.
Right.
Yeah.
They're just going to be looking so out of breath. They might be ashen. They're going to be really gray and have a lot of perioral cyanosis. And really kind of the main part of this sodium nitrite is specifically that it's going to cause profound methemoglobinemia. And it's really what I want folks to get out of this talk is like, there's a lot of things that can cause this, but there's specific interventions that we need to recognize as EMS. And when you make your transport decision, kind of factoring that in. So let's say you walk in the door, you see this gentleman kind of, just looking like crap laying on the couch.
Mm-hmm.
Your first set of vitals, he'll probably be like tacky, let's say like 120s, maybe a little bit hypotensive, like high 90s. You put him on the monitor, he's going to have just a sinus tachycardia. There's not going to be a whole lot of EKG changes there. But then when you put the pulse ox on, it's just going to be persistently like 85. Throw him on some non-rebreather, try and bring that up, 85%. Throw in a little high flow nasal cannula, 85%. You're not going to see any change in that. And a lot of that comes from how the methemoglobinemia actually affects your pulse ox sensor. So some places you got money, you've got the rainbow pulse ox sensor that it can detect carboxyhemoglobin, so your CO. Some can even detect the methemoglobin, the SP-Met. And so it just kind of depends. Like the Zoll, if you have the right probe, it'll do that. The LifePak will do that. If you have the specific like RAD57, if you've ever had like the separate pulse ox one, that one will do it. There's ones that are designed specifically for hazmat, things like that check for some other stuff. And so that's kind of the main thing is these folks will just ingest this powder. It's absorbed pretty quick, like 20 to 30 minutes, and then it causes really, really profound methemoglobinemia. And so their body's just not going to be able to transport oxygen from the lungs out to the tissue, to their heart, to their brain, things like that.
So here's my question. So I had a buddy one time. He had a kid who was teething. They put benzocaine on his gums.
Yep.
And the kid got this. I mean, he was just very colicky, crying, fussy. And so they got called out for a kid with respiratory distress and just fussy baby, right? Yeah. So he told me they started an IV, and he's like, the first thing I noticed when I started the IV is the blood was like chocolatey looking.
Yep. Yeah. And you start to see that like 50 or 60% methemoglobin content in the blood.
The chocolatey blood. Yeah. And he was like, I was like, what the heck? Is this an alien? Like, like, what is this right now?
Yeah.
And so I get like that's a thing you can find once it gets to a certain, point. You can see that chocolatey type blood. But the baby, I'm guessing it's like just fussy because they're hypoxemic. But what type of mental status would this person be exhibiting? Would they be angry, violent, combative, unresponsive?
Yeah.
Is it a spectrum?
So they're going to go from altered. They're going to, maybe start with that respiratory distress of just that feeling that they can't catch their breath. And it's not going to be the same driving mechanisms for dyspnea that somebody who is hypercarbic has, right? So think about the COPD or who they're just super hypercarbic. This is going to be somebody who is truly hypoxic and not necessarily hypercarbic, because they're not even delivering oxygen to the periphery, but they're able to offload all that CO2. So they're going to very quickly become altered and then just unresponsive. So they're not going to have a lot of the same signs as somebody who is having respiratory failure driving their hypoxia. It's really an actual like chemical hypoxia.
Yeah, have you ever seen where they will go into like the decompression chambers or the exactly, the decompression chambers, and they take them off oxygen and they're at like 25,000 feet, and they can blow off all the CO2 in the world. So it's not that feeling when you're underwater and you're like, I gotta come up right now. It's not that panicky feeling.
Yeah,
it's more so almost like they're just like high.
Right.
Like
it's just a loopiness from the lack of oxygen delivery to the brain itself that's really getting them.
Yeah, so like you said, there's no CO2 burden or anything. They're exhaling probably fine, but probably even blowing off a lot of CO2.
Yeah.
If they're tachycardic, high metabolic demand, but you're just not meeting it with the oxygen. So what's happening at like the hemoglobin level when somebody takes sodium nitrite?
Yeah, so we're going to break into some biochemistry here.
Let's do it.
It wasn't, I didn't get an A in biochemistry, but, there's something.
But I didn't get a D, so.
Yeah. The nitrite itself, so it's not the sodium. We don't really care about the sodium. The nitrite itself is actually going to oxidize the iron on your hemoglobin from 2+ to 3+. So you go from, I think it's ferrous to ferric. You have to check me on that.
Changes the entire shape of it.
Yeah, and so your binding affinity for oxygen basically is going to totally change. And so you're going to go from normal deoxyhemoglobin trying to pick up oxygen and transport it to methemoglobin, and now it's going to basically shut down and block that transport of oxygen itself. And that iron, because it's losing an electron, it's not in the normal oxygen deoxy where it's kind of changing its conformation. It's like chemically unable to transport that oxygen any longer.
Gotcha. So we got this patient, they're altered, they're unresponsive, they got this chocolatey colored blood. Maybe we have some sort of insight that they were in a bad space mentally and they were trying to hurt themselves. Yeah. And so, we have the ability to intubate them. We can try to oxygenate them. You know, we can put as much oxygen there, but if the Uber doesn't want to pick me up, he's not going to pick me up. He's just going to keep going. So how do I address this in the EMS setting?
So, it's really going to be good, aggressive resuscitation. So these patients, because of you have the profound hypoxia, and hypoxemia, so you have no oxygen delivery. You're going to be in totally anaerobic metabolism, building up lactate. But also this nitrite is going to be metabolized in the body to nitric oxide. And so you're going to get that vasodilation the same way you do with any other nitrates, any like sublingual nitroglycerin, anything like that. You're going to get vasodilation with it as well. So these patients are going to have really, really difficult to control cardiovascular collapse. So from the pre-hospital setting, most of it's going to be recognition and then transporting to a facility that has the antidote, which we can kind of jump ahead and talk about that. But I want to go back to the teething baby that you talked about with the benzocaine, because that's probably the number one iatrogenic cause of methemoglobinemia that we see is going to be benzocaine. So particularly in dental procedures, folks might get a lot of benzocaine or any of the other kind of topicals, and that itself can cause this methemoglobinemia. So that topical benzocaine, it only works for a little bit and it works really well. So you're like, oh man, that's great. I'm just going to keep dabbing it on, keep dabbing it on, keep dabbing it on. But when the effect wears off, that's still circulating in your body, and so it can cause that oxidation reaction and cause the methemoglobin to build up, particularly in babies who are, their circulating volume is much smaller. So one drop on that little Q-tip is a lot more for them than it would be for us.
Yeah, I think that's something huge to have on your radar. I remember, do you have kids?
No, I don't.
So I have 3 kids, and when they're teething, it's like, man, you just want to do something to try to fix that,
Yeah.
But and I can't remember the age cutoff, but like you said, when they're very young and their whole blood supply is not that much, it doesn't take a whole lot to taint that a little bit.
Yeah, and there's even folks that they might have a genetic predisposition where they can't basically maintain their hemoglobin in the normal conformation. They're predisposed genetically to methemoglobinemia, and so those folks are going to be even more sensitive. So it's not crazy. Back when we were giving out Dapsone a lot more, it's not crazy that we would give somebody Dapsone and then all of a sudden they'd start having a lot of shortness of breath and stuff, and we'd have to give them the antidote to flip them back over. So.
Yeah, so I get him to the hospital. I hand him over to you, and you go, "You big idiot! You had a cyano kit in your ambulance the whole time."
Well, so you think about that. It's not cyanide, and we have these cyano kits and things. So the hydroxycobalamin is really good at pulling that cyanide off. And actually, how we know so much about sodium nitrite is before we had cyano kits, sodium nitrite was the antidote to cyanide poisoning.
Mm-hmm.
So we would give folks, basically the idea is in the immediacy of somebody getting cyanide poisoning, typically like in an industrial setting where we know that that's something that folks are going to interact with. There's amyl nitrate, which you've ever heard of, like poppers and things. Basically, folks would sniff the amyl nitrate. Mm-hmm. They're absorbing the amyl nitrite, and it's causing methemoglobinemia. And then when you get to the hospital, we give them sodium nitrite IV and try to get them to like 10 to 20% methemoglobinemia. And what that does is now that's going to pull the cyanide. It has a really high affinity for cyanide. It pulls it out of that electron transport chain, allows kind of your body to go back to that normal aerobic metabolism. And then we give them sodium thiosulfate, and that binds it all and you excrete it. So, when you think about, well, this is a poison, and, we have folks that have this and they need an antidote, but actually sodium nitrite can be the antidote for other types of poisonings. So one of the keys is, when you're trying to figure out which place I need to transport this person to, one, think about the ability to support their cardiovascular system. So it's not uncommon that these folks might go on VA ECMO because of all the nitrates and all the other things that build up in their body. And basically we need to support their hemodynamics while they metabolize this, but also calling ahead to make sure that they actually do have the antidote, which is methylene blue. So in both cases, you've got something that it looks like a dye, like cyano kits. It looks weird giving somebody that color medicine, right? Like it's so strange. And then
methylene blue.
It's cyano kits too. Like, it's that like purple, and then methylene blue. It looks, it's like a glowing blue.
It's like something from Jurassic Park.
Like it looks like it should be in a movie. And the reversal of it is pretty quick. So like within minutes, you're going to start seeing increased oxygen delivery to the peripheral tissues. So, these folks, when you see them, they're going to have a ton of perioral cyanosis. Their fingers are going to be blue. They're just going to look ashen because they're not going to have that, like, I don't know, the spark of life that a normal person has, like the normal redness in their cheeks and their mucous membranes and things. But the reversal is pretty quick. But then they still might have, terrible cardiovascular collapse and other things that we have to manage on the side. So from the pre-hospital setting, really the key is recognition. And then you're going to need to anticipate that person's going to crash really hard on you. So if they're not hypotensive yet, having that pressor drip ready to go, whether it's epi, norepi, whatever having you protocols, being able to support their airway because there's going to be a ton of vomiting and things because they usually drink about like half a liter to a liter of this cocktail, and having it come back up. So, really be able to support the I say BLS things, but the suctioning, the rapid transport, all that stuff that we kind of
the important stuff. Yeah.
But then your transport destination is going to be key. So, we were talking about eCPR and stuff before we got on here, but, identifying where your ECMO centers, because it's probably that these people are going to go on ECMO.
So does every hospital, like every ER, have access to something like methylene blue?
Yeah, so I asked around the two facilities that I work at. One's a level 1 trauma center, or like the academic place, and they definitely have it, and we can get it very quickly from pharmacy.
Mhm.
Other places, some of the smaller outlying facilities, you may not have it. Like freestanding's definitely not. Some of the smaller non-trauma community sites may not have
They may
it.
have to run to Walgreens.
Right, yeah, and it's like, this thing that it's probably in a dusty bottle on a shelf somewhere, and somebody's got to run.
It's no longer blue.
Right, yeah. So, it's not something that's given super often, but when you need it, you need it. So making sure that the facility has it ahead of time is going to be key.
So methylene blue is a nitric oxide scavenger. Is that correct?
Yeah, so it's going to reduce the hemoglobin back from 3+ to 2+, and then it's going to help scavenge all that nitric oxide. So, folks will use it as like a last line pressor and things in some ICUs, particularly like cardiovascular ICUs.
Mhm.
It's going to scavenge all that nitric oxide. And so, I remember a case in residency when I was covering the ICU overnight, and it was like the last ditch thing that we could do for a patient was some methylene blue. And it's not without harm. Folks with G6PD deficiency, you can have some issues if you give it. But in this case, like, you got to do what you got to do,
Yeah.
Um,
So just for the folks at home listening, what is a scavenger? What does that mean?
so it's gonna help take that nitric oxide and its activation kind of in your periphery and in all your smooth muscles and everything, and it's gonna bind that, and it's gonna basically reduce its ability to affect and help you excrete it.
Gotcha. So when you say bind to it, how does it do that?
Oh, that's a good question. I did not.
I'll just mess with you.
I did not look that up ahead of time. That's a question for a real toxicologist, probably.
So I mean, it's going in there because I always think about, and tell me if I'm thinking about this wrong, but like nitroglycerin, you're not actually like giving nitric oxide, right? You're giving something that's going to go into the endothelium and then release nitric oxide into the out of the endothelium. When you give something like nitroprusside, for example, you're actually giving them something that's exactly going in there and dilating it out.
Yeah.
And so the nitric oxide is a natural occurring, you got nitric oxide and prostacyclin that kind of get released from that endothelium to keep the vessels plump and keep platelets from sticking together.
Yeah.
And so I think of it like you got all this nitric oxide in there, and that's what's causing the vessels to dilate out. So you give something that goes in there and says, you're coming with me, right? We're getting out of here.
Yep.
Like it gathers all of that up and takes it with it. Is that what a scavenger is? What is a scavenger?
Yeah, so that you're right. It's going to help kind of basically remove that from the circulation and remove its ability to affect the tissues and the smooth muscles and all the other things you were talking about. And one of the unique things, you're talking about releasing from the endothelium is the nitrite itself will be metabolized to nitric oxide. So you're introducing exogenous, basically vasodilation in there when you're given this.
Awesome. So just a quick recap. We may show up. These patients may have taken this. You said that consistent findings, like they have a pulse ox that's like staying pretty much the same. Like
it stays exactly at 85. So
why is that? What's with the 85?
Yeah. So if you look at how a normal pulse ox works, there's basically two little LEDs in there at two different frequencies, and it's measuring the absorption between those. And one, for a normal person is oxyhemoglobin, and the other is deoxyhemoglobin. And so it's measuring the absorption ratio of those two, and it gives you your percentage, basically what percent is oxygenated versus not. What happens if you look at the actual absorption kind of chart and spectra for methemoglobin is it absorbs at both of those frequencies that are present in a normal pulse ox the same. And so its ratio is 1. And in whatever math is inside there, whoever came up with the pulse ox.
Yeah, can you explain that for the people at home?
So whatever math goes into that ratio to figure out your percentage, that equals 85. So
That's interesting.
methemoglobin has an absorption ratio of 1 because it absorbs, if you look at the little graph, basically at those two wavelengths, it absorbs the exact same. And so that ratio is going to be 1, the higher your methemoglobin concentration gets.
Sounds like your electrical engineering background is coming in handy
Exactly.
a little bit.
So, you hear folks have like, you talk to your supply guy and he's like, oh, we got these rainbow probes, or the rainbow probes for the monitor are so expensive. You keep breaking them, things like that. So what they mean by a rainbow probe is that it has multiple different LEDs. So when you switch it over to the carboxyhemoglobin setting, right, you're trying to measure SPCO. It's going to use different frequencies and different math ratios to figure out what the percentage of basically carboxyhemoglobin to all other hemoglobin is. And that gives you your percentage there. So if you have a patient in a house fire, you're trying to see what's their CO level. That's how that measures. You can get ones that measure methemoglobin as well. Most of the rainbow probes that you're going to get for your Life Pack, your Zoll, pretty sure Tempest has them as well, is going to also measure your SP Met, so your methemoglobin percentage. And so again, it's using different wavelengths of little LED lights in there. So it's hitting that graph of absorption in different spots, and it's going to be able to give you the appropriate ratio. Now, when I tried to look at the actual like manufacturer documents, it really is only accurate up to like 17%. So the normal percentage of methemoglobin that these folks are going to get, particularly when you start seeing the cyanosis, you see the altered mental status, you see the respiratory distress, things like that, you're getting upwards of like 40 to 50. So I tried to look at some of the case reports for the highest level that somebody survived. And I think it was like, there was one case and I think they got put on ECMO and it was like 90%, but everything happened so quick. They got to the hospital, they got the antidote, they got put on ECMO. But 55% was the lowest that I saw where it was fatal. And so it really doesn't take much. It's like a couple milligrams per kilogram of actual dosage. There's no LD50 for humans. There's only mice and rats. But in the case reports, it was like a couple of grams of this mixed in a jug and then consumed was enough to cause pretty profound methemoglobinemia.
I'm assuming you would probably see some type 2 ischemia ECG findings as well.
Definitely.
Flip T waves, maybe even some depression, elevation.
Yeah, and if you think about it, like full on STEMI criteria, that's full thickness infarction of the muscle. So if you have a really high methemoglobin level and you're not delivering any oxygen, you're going to get full thickness. Now the question is, are you going to see reciprocal changes? Because we're not knocking out one coronary artery, we're knocking out all of them, right? Globally, that heart is going to be angry and it's going to not want to, it's going to not get any oxygen delivery. So you're going to see pretty crazy EKG changes and stuff on there from that myocardial ischemia.
It's yeah, I was thinking like if you already had some atherosclerosis or you had some narrowing in areas, obviously those are going to be the areas that take the hit first.
Right. Yeah.
And so, maybe you see a little bit of a reciprocal change if they already have cardiovascular disease. But like you said, it's almost like the type 2 ischemia you see when you have somebody who's anemic, and you're just not delivering the oxygen there. So you may see some ECG findings as well.
Yeah.
Here's my question. I don't know, this may be an inappropriate question, but like, if somebody is thinking about hurting themselves, it seems like we have a ton of chemicals in the house that could do that, right? Is there a specific reason that you've heard of that people are like ordering this stuff on Amazon? Like, what is the I don't know, I don't want to say rationale because that doesn't make sense, but like, what's the thought behind utilizing this agent?
Yeah, so there's an online community that is kind of advocating for this peaceful passing, right? Like if you've decided that you don't want to be on this earth anymore, we think about countries that have, not necessarily euthanasia, but like the ability to pass peacefully, utilizing medications, chemicals, things like that. And so in the United States, that's not allowed. And these folks are kind of managed from a psychiatric standpoint, but there's communities online where folks are advocating for this. They have suicide kits, and so in the case reports you read about this, there were folks that were found that had the directions printed out from a blog about how to mix this, how to consume it. You can get these kits mailed to you directly where they have antiemetics, they have like antihistamines like famotidine to calm the stomach, things like Reglan to promote gut motility to increase the absorption. And one of the reasons that folks choose this one is that it's almost like the helium bag over your head, where you don't sense that buildup of carbon dioxide, that sense of shortness of breath, like you do with just like trying to suffocate yourself, because you're not delivering oxygen, but you're able to exhale that CO2 appropriately.
It's almost euphoric.
Right. And so, it's like the nitrogen narcosis that divers get, where they have no idea that they're becoming more and more hypoxic because they're just drunk off the nitrogen.
Mm-hmm.
But these folks get drunk and basically altered off the lack of oxygen delivery. So there's published forums and stuff out there where they talk about these suicide kits. And another thing is, these folks don't want to harm responders. So if you think about detergent suicides and things that were more popular back in like the late 90s, early 2000s, a lot of those produce things like hydrogen sulfide gas, which that's incredibly dangerous to responders, right? So you see these pictures of folks have like hand-drawn skull and crossbones on their car or their bathroom, where they taped up the windows and doors trying to increase the concentration. But if somebody walks in there without respiratory protection and they take a breath at a high enough concentration of hydrogen sulfide, it's going to take them down too.
Mm-hmm.
And these folks don't want that on their mind. So this is something that there's basically no dermal absorption of this cocktail. If you get their vomit on your hand, it's not going to cause you to then start to have effects, things like that. It's not going to be some gas that's going to affect your neighbors, affect responders, things like that. And so one of the case reports was 2 guys had a suicide pact, and they both drank it together, and they both were successful in their endeavors with that. So I think that's kind of why it's become more popular. And if you look, New York State publishes some kind of numbers, and they didn't have any cases reported of this, whether we were looking or not, before like 2019. But they've seen a really drastic rise since then, particularly like 2021, 2023, things like that.
Interesting.
Yeah.
Well, Harrison, this has been awesome, man. Thanks so much. I really appreciate it. I think that, it may be like sodium nitrite maybe not be something that we're thinking of, but methemoglobinemia is something that can happen, right? Yeah. And so like whether it's the fussy baby that has chocolate covered blood when you start an IV, like sometimes it's just those little nuanced things that you pick up that makes you go, I wonder what we should do. And I'm still in this area where, like, if I was working in a 911 district, we had a small little hospital, I would wonder, is it wasting time if they don't have methylene blue? Am I wasting time to go there when I could go right to this one that maybe does have it? So I do think it's worth a call and saying, hey, this is what we think it is. Do you guys have this? That thinking ahead,
Yeah, and I would say that if you can reach out to whatever your poison center is, right? There's a national number, 1-800-222-1222, right? That's going to get you to the poison center. They're going to be able to tell which hospitals have the antidotes, right? Like that's their job.
They can. I didn't know that.
To have that list, right? And they're going to be able to provide you some of that guidance. In this case, picking up, like if there's one tidbit I want folks to pick up on this out of everything about methemoglobin is you're going to see that persistent pulse ox of 85. Like you walk in, you see it's 85, like I want those antennae to go up. And then from there, transport decisions and stuff can come from the poison control center, because they're going to have that information, and they're going to be able to make calls to folks ahead of time and say, hey, this crew's bringing this patient in, this is the antidote they need, right? And they can get the ball rolling, because really it's a time sensitive thing. Skipping that small hospital that doesn't have it is probably going to save that person. I am not your medical director. I'm not telling you to make transport decisions, but if it were my system, I would say absolutely skip that smaller hospital and go to the larger center that guaranteed has it.
Awesome, man. Well, thanks so much for coming on. This has been great. I want to keep picking your brain on future episodes on other topics. So
absolutely.
Thanks, man.
No problem.